So my name is Tom Coates. I'm a haematology consultant in Royal Devon and Exeter in the UK. And a piece of work that I've been doing is around novel guideline for novel technology for creating a consensus guideline in AML. So as a clinician, you want to know that you're treating in line with current consensus and that you're practicing up-to-date medicine. And we know that the evidence base is always changing, and we have things like multidisciplinary team meetings to support this. Clinical guidelines are there to help support this as well. But we know that clinical guidelines take a long time to create, and in a sense, they're outdated as soon as they're written. So again, as a clinician, it can be hard to know where a guideline is out of date or in what way has it been replaced by new data. So therefore, we wanted to explore the idea of creating a consensus guideline in a nimble way that was still able to capture the necessary complexity of the disease in question, but do this in a rapid way. And we were particularly focused on patients with AML who are fit for intensive treatment. So AML is getting increasingly complex, more and more genomic information, minimal residual disease, decisions about transplantation. But at the beginning, at the time of diagnosis, the main question is around how are we going to treat this patient if they're going for intensive treatment. In the UK, all patients are eligible for DA chemotherapy, and based on NCRI clinical trial data, then for higher risk patients, we commonly use FLAG-IDA because of the higher induction rates that it can achieve. But there are strict eligibility criteria as to whether the novel treatments will get funded on the NHS. So these are gemtuzumab, midostaurin, and CPX-351. So a couple of examples, maybe just to illustrate this then. So for a younger patient with AML who has AML with myelodysplastic related changes, because the phase 3 trial was only had patients over the age of 60, it's not entirely clear whether CPX, even though it's licensed and funded for use in the UK, is the optimal treatment. Likewise, for a patient with intermediate risk AML with an NPM1 and a FLT3-ITD high mutation with a high allelic burden, the patient would be eligible for both DA plus gemtuzumab and DA plus midostaurin. And although the NCRI AML-19 trial is trying to look to see whether it's safe and efficacious to use both, at the moment it's an either or. And again, having some guidance around that is always helpful. So we wanted to create a consensus guideline that would cover all of the scenarios that might reasonably occur in a new presentation of AML. And to do this, then we needed to know that we could map out the different scenarios. To do this, we combined drug eligibility criteria and genetic risk stratification into a digital format. And this would give us the whole range of treatment scenarios. So that meant we started with the 4 different ELN genetic risk categories. We had adverse risk, intermediate risk, and 2 favorable risks, one with a core binding factor mutation and one without. And then for each of these risk groups, we knew that a patient might be eligible for none of alongside the DA and the FLAG-IDA, they might be eligible for no novel therapies or just one of gemtuzumab or midostaurin or CPX, or they might be eligible for either gemtuzumab or midostaurin, either midostaurin or CPX, and so on. And this gave us, therefore, a total of 32 theoretical scenarios that we thought could occur. But these scenarios aren't very intuitive unless you create a clinical case. So we then artificially created a batch of cases that covered the full range of genetic and clinical phenotypes in AML, and ran these cases through a series of decision trees that we made that reflected the eligibility criteria and the ELN risk groups. And that meant we had an exemplar case for each of what turned out to be 22 biologically plausible scenarios. And we could then take each of these scenarios and share them with a panel of 9 UK AML experts, and using a Delphi consensus method, see whether we could agree on consensus treatment for each of those scenarios. And we asked that question as to how they would treat for a patient under 60 and for a patient over the age of 60. And then we next analysed real cases of about 2,500 AML cases, which showed that it confirmed the existence of 21 of the 22 biologically possible scenarios, and showed that our novel approach could generate a consensus in about 98% of cases. So this was really pleasing. We were able to complete this work with just 2 rounds of a Delphi consensus. And we compared our guideline to an existing guideline, the European, the ESMO guidance. And we did actually see that there were noticeable differences in some of the areas in terms of the guidance. And we think that that's perhaps due to our greater rigor and actually having a specific case for our experts to review. And we've created a web app so that clinicians can input their patients' clinical data and clinical and genetic data to calculate what they would be eligible for in the UK. And that therefore can link to the consensus guidance as to currently how recommended to be treated. And we're now wanting to continue this work. So we've shown that it can be done, but we want to make sure that we can now update our guidance so it can be a ready resort for people to go and look at, continually. So we've got a living guideline. So we're working with the NCRI as to whether we can do this, update this easily. And we know that we can tweak our algorithms to be able to create new exemplar representative cases as and when licensing eligibility criteria change. So, it's an exciting time that we hope to therefore be able to make this guideline readily accessible on an ongoing basis.